And now we have our first speaker. Dr. Fatima Cardoso is a senior consultant in medical oncology. She is the president of the Advanced Breast Cancer, or as some of us know, the ABC Global Alliance in Lisbon, Portugal. So welcome, Fatima.
Hello, Sherry, and hello, everyone. I have to start by apologizing for my voice, but I'm ill, and I'll do my best to make it as loud as possible throughout my talk. So I'm going to share my slides. Please let me know if they are
They're fine.
singing. Okay, thank you. And as Sherry said, I've been dedicating a lot of my life and my career to advanced or metastatic breast cancer. And today I will speak to you a little bit about this um, setting of breast cancer when it occurs in male patients. So these are my disclosures. And I'm sure you, because we had a full day yesterday, and because of course you are familiar with this disease, that you know that male breast cancer is considered a rare disease. About 1% of all male cancers and about 1% of breast cancers. But metastatic or advanced breast cancer is even a rarer disease, fortunately. But let's say that about 1/3 of breast cancers, even if diagnosed early and treated properly, they will have a relapse. They will become metastatic, which I will explain a bit more in a moment. But this disease is even rarer. So we do not have any randomized trials and probably will never have exclusively dedicated to male patients with metastatic breast cancer. Therefore, we have to extrapolate our strategies from what we have learned so far for female breast cancer. However, a lot of us have been fighting and advocating for male patients not to be excluded from trials. And this has led for a recommendation of the FDA for industry in 2020 to not to exclude male patients from trials of new drugs or new treatments unless there would be a very good reason to do so. It took a long time. I show you here an editorial I wrote 10 years before, already asking for not to exclude male patients from new treatments trials. But at least now, the newer trials, they have included male patients. And so we do have some data on the efficacy of these new treatments in males. Another point before moving on is that we know that when we look at the survival, it looks like male patients do worse than female patients in all the stages of the disease. However, when we look at the characteristics of male patients, because they have more comorbidities, this is other diseases, they are also usually older at diagnosis, and men usually have a lower life expectancy than female. And the most important point is that they are usually diagnosed late. So when we adjust for all of these, the relative survival is very similar, and focusing there on stage 4, which is another name for metastatic or advanced breast cancer, is very similar between males and females. So the most important thing is to avoid late diagnosis. Also because a major difference between metastatic or stage 4 and the other stages is that unfortunately so far stage 4 is incurable. It is treatable. There are definitely a lot of options, but eventually it is not curable. So the most important is always to diagnose early and treat as early as possible. A few points here about the subtypes of breast cancer. I'm sure you have also heard this before, but just to confirm, and simplify in a very simplified way, we have three major subtypes of breast cancer. One that we call hormonal dependent or luminal, and these are the tumors that have what we call hormonal receptors. Then we have a group of breast cancers that have another receptor called HER2, and we call these the HER2 positive breast cancer. And when there are no hormonal receptors nor HER2, we call it triple negative. And this is a very broad simplification of the division of breast cancer subtypes, but it's much more complicated than that. When we look at the microscope, there are many different types of breast cancer. And now with this new technology of molecular classification, we also know that each of these subtypes can even be subdivided in other subtypes. What I wanted to call the attention is that looking at the three major subtypes, the hormonal dependent is the most frequent. In females, it represents about 65 to 70% of cases, but in males is even higher, 95 to 98% of cases in male patients have estrogen receptor positive tumors. The HER2 positive occurs in about 15% to 20% in females and less than 10% in males. And the triple negative is really extremely rare in male patients. So the one important take-home message is that if you get a diagnosis in a male patient of a triple negative breast cancer or a HER2 positive, or if ER is negative, we need to ask the pathologist to revise the pathology results. Maybe something happened, something technical that is not providing the proper diagnosis. And so before moving forward with any treatment for HER2 positive or triple negative, we have to revise and make sure that it's really that subtype of breast cancer. Now, why does cancer becomes metastatic or advanced? What you see there is a cartoon. The green cells are the tumor cells, and the tumor cells are actually our own cells, but that they have lost some characteristics and gained some other characteristics. So, for example, a normal cell, the cell is born, it has a specific function. For example, the skin cells, they have a function. The neurons, the brain cells, they have another function. They have their own function for a limited time of life, and then they naturally die and are replaced by new cells. What happens with the tumor cells is that they gain immortality. They lose the capacity to die. And so they don't die, they just continue to live and to divide. They also don't have a function. And so they use all their energy to multiply, to divide. And they gain another capacity, which is to be able to invade the blood vessels, the lymphatic vessels, and leave the tumor and go in our circulation, in our blood circulation. And so they are capable of reaching other organs. They are no longer in the breast, but they go to other organs. So these are the main characteristics of the tumor cells and the reason why we have metastatic or advanced cancer. Why do we use this terminology? So you have seen that I called stage 4 breast cancer or metastatic or advanced. So stage 4 or metastatic is what you see in the images of PET on your right, is when the cancer has spread to other sites than the breast. And the most common sites for breast cancer are bone, liver, lung, brain, and lymph nodes. Locally advanced is when it's very advanced locally in the breast and the axilla, the armpit, below the armpit. But it is so advanced that it cannot be operated. So we call this inoperable locally advanced. And because we wanted to incorporate in our efforts these two situations, we call the guidelines, the conference, and the global alliance we called Advanced Breast Cancer, or ABC. Now, why is it so important to focus on the management of advanced breast cancer? What you see here are, and in the top are results from the, the US database, the SEER database, and you see the evolution of the survival at 5 years for localized breast cancer and for metastatic breast cancer in the square. And you see that from the 90s until the early 2000s, the improvement was minor and very, very slow. What you see in the bottom right is real world data. It comes from France, but it's the same everywhere. There are several curves, but you see that they are all overlapping, and you see the numbers below, meaning that the median survival took a long time to improve and very, very slowly. Fortunately, since the early 2000s and since 2013 until now, we have seen advances to improve the survival of advanced breast cancer for the hormonal dependent subtype and the HER2 positive subtype, which are the ones that matter the most for male patients. When we look at what happened in the early breast cancer for so much advances and lower mortality, and what could we apply in advanced breast cancer, we saw that things that made a difference was to be treated by a multidisciplinary team specialized in breast cancer and treating according to evidence, according to guidelines. All these leads to improved survival. And so the first thing you should do is to make sure that you are being taken care by a team, not an individual physician, and a team that is specialized in breast cancer, and that you are given what we call evidence-based medicine. Because if it is like that, you will have a bigger chances to have an improved survival. And of course, we also want to have individualized as much as possible therapy, and always suggest that the patient has an active participation in the decisions and respect the patient preferences. This has led to the creation of what we call the ABC Conference that takes place every 2 years in Lisbon. And the objective is to define the guidelines, how to manage metastatic or advanced breast cancer. Out of the conference, we also created the alliance because we saw that there was a huge need from these patients to have dedicated resources, and also huge need from healthcare providers to be able to collaborate and achieve better results. So today we are more than 300 members. Our members are other organizations in more than 100 countries, and the work of the alliance that you can find in the website, and I advise you to go and have a look at our website. The work is really to collaborate, to share resources and knowledge, and to advance the outcomes and improve the outcomes of patients living with this disease. 10 years ago, we have defined these 10 priorities. I will very briefly mention them. We wanted to double the median survival. We wanted to improve quality of life. We wanted to have data because today we do not know how many men and women are living with metastatic breast cancer. And this is because the cancer registries do not register relapse. We wanted also to ensure that every patient is treated in a multidisciplinary team. We wanted to improve communication and the information, the specific information needs from patients living with metastatic disease. Also ensure access to other support services like psychological support, social support, financial support, and other, and particularly palliative care support, and what we call supportive care, which is control of symptoms. We also wanted to fight the stigma and isolation improve accessibility to all types of needed treatments, and improve the legal rights of patients, namely the right to work, or continue to work if they wish to do so. And this was 10 years ago. So in a couple of days at ABC 8 in Lisbon, we will provide a report of what happened in these last 10 years for women and men living with metastatic disease. And we will launch our new 10 goals for the next decade until 2035. So I hope you will be able to join us either physically or virtually, since it's going to be a hybrid conference. In our guidelines, we have also always added from the beginning specific guidelines on how to manage metastatic breast cancer for male patients, and I will briefly review those with you. Also, you have the ASCO guidelines, the American Society of Clinical Oncology, that has also issued management guidelines for male patients with breast cancer, including metastatic. So, some examples of our ABC guidelines. Clearly state and be very clear about the goals of treatment. In a setting of an incurable disease, we want to have this balance between quantity and quality of life. And this is a very personal balance. But we have to be sure that with the new treatments, we can improve survival if possible, but if not, that we can improve or maintain quality of life. And perhaps in the near future, we may be able to transform some subtypes of breast cancer, metastatic breast cancer, into a chronic disease. So if our goal is to treat for as long as possible with a good quality of life, then a couple of notions are important. The toxicity of the treatments is crucial, and we need to pay attention. We also should not be afraid to reduce the dose. And I know this is a fear that some patients have, that if they complain about side effects, they will lead to a reduction in dose, and that will be bad for the control of the disease. However, you should know that we use too high doses. We don't need so high doses. And this has to do with the way we've been developing treatments. And those reductions are acceptable, are very often needed. They do not compromise efficacy, and they are better than interruptions of treatment. We have a lot, fortunately today, a lot of oral treatments. And of course, these are more convenient, cost-effective, and allow the patient to maintain social and work responsibilities. And because that we have different options that have similar efficacy, we can choose based on toxicity. And for that, we need to know the patient's preferences in terms of toxicity. An example, someone who uses the hands for their job, they do not want to have what we call neuropathy, which is a side effect that affects the nerves in your hands and feet, and makes it very hard to hold things with your hand or with work with your hands. But for someone else, losing the hair might be more important because they have a more public work. So pay attention to the preferences is very important. How do we choose among the different options? So we try to tailor the treatment considering characteristics of the patient and characteristics of the disease. And you see here a long list of factors that we can actually simplify and classify into patient characteristics such as the age, other diseases that the patient may have, the tumor characteristics, biomarkers, I'll come back to this, and the disease characteristics. For example, what did the patient receive when the cancer was diagnosed in the early setting? What was the response to those treatments? And again, patient preferences, as we discussed. For biomarkers, there are not so many of biomarkers that are important, but there are a couple that are very important for our decisions. However, I want to call the attention again for the importance of having a high quality pathology. And then if you have access to the different treatments, then it's worthwhile to go look for the biomarker. For example, the BRCA mutations, which are more frequent in male patients, we now have a treatment directed, which are the PARP inhibitors. So it is important to ask for that biomarker. There are a couple of other biomarkers like ESR1 mutations of the estrogen receptor, because we have new treatments against that as well. But if we don't have access to those treatments, it doesn't matter to ask the biomarker. Something else I want to explain about metastatic disease is what we may call the natural history. So let's start from the left. You see there a tumor, and you see that the tumor is not the same, has different cells. We call that tumor heterogeneity, and that is responsible for the fact that not always the tumor responds well. But let's say we give it a treatment. Usually there is a response, the tumor becomes smaller. But after a while, the tumor gets used to the treatment and develops what we call resistance and grows again. And when it grows again, we call progression. And you see that the tumor has become even more complex with a lot more alterations. What do we have to do? We have to change the treatment. We change the treatment, give another treatment, and hopefully there will be a response as well. So that tells us that we need to find a way to know the biology of the metastatic disease, if possible, during the history of the disease several times. And we also need access to many types of treatments. And this is something we all have to fight for, because it's not good enough to have just one treatment. For metastatic disease, we need several treatments because the tumor gets used to the treatments that we give. Now, what type of treatments do we have? We have what we sometimes call an unselected treatment, which is chemotherapy. Chemotherapy targets the cells that divide, and I explained to you that the tumor cells divide very quickly, and that's why tumor cells are sensitive to chemotherapy. And then we have more targeted treatments. For example, endocrine therapy or monotherapy is against the hormonal receptors, and anti-HER2 therapy is against the HER2 receptors. And today we have other types of that we call missiles directed to certain alterations of the tumor cells. Now, if you remember what I told you, 95 to 98% of breast cancer in male patients is ER positive, is hormonal dependent. So when we have metastatic ER positive disease, the most important treatment is what we call endocrine-based therapy. Even if you have visceral disease, what does that mean? Even if you have metastasis in the liver, for example, that is not a reason to go for chemotherapy, because what is most efficacious is endocrine therapy. There's only one situation where we can go to chemotherapy, and this is a complex trial, but it's just to tell you there is a very small proportion of patients that has what we call a visceral crisis. So a very aggressive tumor that is growing very fast and affecting the function of a very important organ, such as the liver or the lung. In those situations, we may have to go for chemotherapy. But outside that, endocrine therapy is our preferred option. Now, let's say that the patient had at diagnosis a stage 4 or was treated quite a long time ago for early breast cancer, then tamoxifen is one of the preferred options. But we also can and can use an aromatase inhibitor. For men, we prefer to use the aromatase inhibitor together with something we call a LHRH agonist. And this is because there is a complex endocrine loop that will lead to the contrary effect that we want. We want to block the tumor. But if we give an aromatase inhibitor without the other, the Zoladex, then we may lead to stimulation of the tumor, and that's what we want to avoid. Apart from these notes that I have given you, the other options that we give to male patients together with endocrine therapy are exactly the same as we give to female patients. And the most important one is what is called CDK4/6 inhibitors. These agents are given together with the endocrine therapy, either tamoxifen, fulvestrant, aromatase inhibitor, and they can be given in first or second line. I will show you just the results of one trial and why I wanted to show you this is that you can see that the median survival in this trial was over 5 years. So this proves that we have been able to improve the survival of this subtype of metastatic breast cancer. Now, a word of caution about, and just calling the attention that we never had such benefit with chemotherapy, and that's why now the aromatase inhibitors or tamoxifen with a CDK4/6 inhibitor is the preferred option for first line. Now, I wanted to call your attention that there are some interactions. For example, we cannot combine tamoxifen with ribociclib because of a cardiac problem, but we can combine it with abemaciclib, which is another CDK4/6 inhibitor. And why am I bringing you this? Because I had a patient recently, a relatively young patient, with stage 4 metastatic breast cancer at diagnosis with a lot of bone diseases. And we discussed very candidly the side effects of the treatment, of giving him, for example, an aromatase inhibitor and Zoladex, and the fact that that would have a huge impact in his sexual life. And he said that he would rather avoid that for a while, for as long as he could. So we ended up together deciding to test if we could give tamoxifen and abemaciclib and watch very carefully if there was a response or not, or if we needed to add the Zoladex. Unfortunately, there was an excellent response, and he knows that when the disease is worse again, we will have to add the Zoladex and impact on his sexual life. But it's just a case that shows that we can listen to patients and we have options to adapt the treatments to the side effects. So summarizing, the first-line treatment of metastatic ER-positive disease, very small group of patients need chemotherapy. Another small group of patients may have hormonal therapy alone, but for the vast majority, the standard of care is hormonotherapy and the CDK4/6 inhibitor. And if you live in a country or if your coverage do not allow you to have a CDK4/6 inhibitor, the next best option is hormonotherapy alone, not chemotherapy. And then after that, it becomes very complicated. And this is the algorithm. Don't worry, I'm not going to go into the details. It's just to show you that after first line, we need to have the biomarkers, and we have different options according to the different biomarkers. We have also other options that don't need biomarkers, but it has become even more complex. And the algorithm that we are going to do in a few days at ABCA will be even more complicated. A few more notes about the treatment. So I already told you that we have a PARP inhibitor against the BRCA gene. And so we need to offer genetic testing, counseling and testing to all male patients with breast cancer. And at a certain moment, we will have exhausted all endocrine therapy options, and we will need to go for chemotherapy. And in chemotherapy, we have many options of treatment. We will favor the oral ones, and the guidelines are the same as we use for female patients. And one last note to say that now everybody speaks about antibody drug conjugates, which are ADCs. ADCs are chemotherapy. They are just a smart way to give chemotherapy. And in this cartoon on your right, you see that the antibody functions as a bus. It has coupled to them, to it, several molecules of chemotherapy. And it goes within the cell and frees the chemotherapy within the cell. And the aim is that it has less side effects and it is more efficacious. One of the first ones to be developed for ER-positive disease was this TDXD, or trastuzumab deruxtecan. There are many others now that go into that complex algorithm, and of course, unfortunately, they are not without side effects. So the take-home messages for treating this kind of metastatic ER-positive breast cancer is that we should use several lines of endocrine-based therapy before going to chemotherapy. We should give the same options to men, preferably with an LHRH agonist, than we give to female. And I made here like a prioritization of the different agents that we have. So into must have, very important to have, and others that if we can afford it, it would be good to have. And I did not have time to go into all the details, but I'm happy to answer any questions about any of these new treatments. Just to show you that the ASCO guidelines, they go through these different recommendations as I explained to you, and basically it is the same that I told you. Just a note saying that testosterone or androgen supplementation should not be used by men with breast cancer because it fuels the tumor. It leads to increase of the tumor. And of course, we have to think about specific issues and concerns regarding having a diagnosis of breast cancer in men. The delay we already spoke, but also the shock and the stigma of having a female cancer. And fortunately, the lack of support and inappropriate information is being tackled by the Male Breast Cancer Global Alliance, as well as the ABC Global Alliance, because we never forget our male patients living with metastatic disease. And you can also see this, it's a small 1.5 minute video, and we also added a man on about the stigma of having metastatic breast cancer. So I invite you to go to our website and have a look. And so I'll finalize by giving you the dates of the ABC8 conference and asking you to, if you haven't done yet, to please come either to Lisbon or connect to us virtually to listen to what is new, what has happened in these last 10 years, and what will be the new guidelines. Thank you very much.